Hello, and thank you all for joining us today in our presentation on Nova Scotia's perspective of Canada's long-term care crisis and COVID-19. My name is Hunter, and I'm joined today by my colleagues, Robert, Riley, and Mahbubur. I first want to start off by acknowledging that Dalhousie University is located in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. We are all treaty people. Our presentation will cover our problem statement, COVID-19 and long-term care, or LTC for short, LTC in Nova Scotia, LTC in Canada, our options and recommendations, and finally, how we will implement our chosen recommendation. We have identified the problem as underfunding and inadequate standards of care have led to a system of long-term care in Nova Scotia that fails to meet the needs of its clients. As a country, Canada has had an unusually high number of deaths in LTC in comparison to the rest of the world. Only 18% of Canada's COVID-19 cases were in LTC, but it has accounted for 66% of deaths in Canada from COVID-19. This is nearly twice the global average of 38% of deaths in long-term care. In Nova Scotia, the number unfortunately is even higher, with 88% of deaths from COVID-19 in the province being located in LTC. In response to this crisis, the government introduced the Health Protection Act order, which restricted outside access to LTC to help reduce the spread of COVID. This act made it so that family members could not visit and that staff members who worked in multiple LTC locations would only be allowed to work in one place to reduce transmission. The government commissioned the Northwood Review as well, which identified major factors of the outbreak being shared room and staffing shortages. And this report recommended $5 million in new LTC spending and an additional $3.1 million in LTC conversions in 2021. COVID-19 shone a light on the issue of LTCs being unable to adequately care for people. We must address the systematic issue and the fact that frontline workers are undertrained, underpaid, and undersupported to confront COVID in these facilities, just as they are undertrained, underpaid, and undersupported to meet the complex needs of residents in general. In Nova Scotia, we're spending 15.8% of healthcare spending to LTC, the highest in Canada, meaning that we're spending more money for worse care than other provinces. We have 7,898 beds in our system located across 83 facilities, 12 of which are publicly owned and 71 are privately owned facilities. And of those 71, 37 are for profit. 5.3% of Nova Scotia seniors are in long-term care facilities, and of which 73% are age 85 or older, the oldest in Canada. Presently, 20.4% of Nova Scotians are 65 or older, which will increase to 28% and between 28 and 31% by 2043. The average age of residents in nursing homes is 88, which is 5 years higher than the average of 83. And in Nova Scotia, our seniors have intensive care needs, which will not be resolved anytime soon. We have many gaps in our LTC system in Nova Scotia. The median waitlist time is 160 days, but can be higher depending upon the region of the province in which you reside. Recently, the province passed a law to try to deal with the issues of long-term life partners being separated by being placed in different LTC facilities. But as we've learned in the Northwood report, shared rooms have also contributed to the outbreak of COVID-19 in LTC. We also have concerns of staffing levels, as presently only the patient ratio to nurses only allow for around 3.4 hours of patient care, which is lower than the 4.1 hours that the Nova Scotia Nursing Union recommends. Lastly, standards in Nova Scotia need an update, as we have seniors that require specialized care that they're not currently receiving a high enough quality of.
When we talk about long-term care in Canada, across all jurisdictions, we spend about $22 billion per year on long-term care, which is about 1.2% of GDP under the 1.7% of GDP OECD average. Long-term care costs in Canada are expected to nearly quadruple by 2050. Currently, we're spending $6 billion in Canada Health Transfer specifically for long-term care, with an additional $11 billion over the next 10 years since 2017 for improvements in long-term care. Canada's spending rate on long-term care is about 2%, which is below the average or below the rate of inflation and below the OECD average of 4.6%. Compared to their OECD partner equivalents, Canadian seniors are also less satisfied with their long-term care at 67%. We need to address this systematic issue. In Canada, 430,000 Canadians have unmet long-term care needs, with 40,000 of them being on wait lists for long-term care and thousands waiting in hospitals, costing Canada $2.8 billion annually. Canadians are really concerned that they're not in the position to care for their families, with 63% of Canadians balancing care and work for family members, providing $25 billion in unpaid long-term care supports. Yet spending is declining. Between 2002 and 2012, there was a 60% decline in long-term care, and according to the National Institute of Aging, that has not improved since in the last decade. Everyone knew that this would have to be addressed eventually. When we originally passed the Canada Health Act, long-term care was concluded as part of extended care services and left purposely undefined with the intention that it would be addressed later. We've waited this long, and because of that, COVID-19 was allowed to ravage through our long-term care facilities, leading to an unmatched level of deaths. Money without standards reinforces existing problems. In the Nova Scotia view, we need a national standard. We're far behind compared to other provinces, having received a D on our health report card, and we spend more on long-term care than any other province, which takes funds away from our other health services, especially with 1/3 of our hospital beds being taken up by individuals awaiting long-term care assignment. We have a large and growing senior population, and therefore believe any national standard should be tied to funding that reflects senior populations in each province. Eligibility, costs, and quality of care and health outcomes vary by province, meaning where you live determines what care you receive and how high of quality it will be. We want to boost up Nova Scotians by introducing a standard, increasing their quality of life as they age. We also recognize the majority of long-term care in Nova Scotia is private for profit, and we need regulations to make for easier enforcement in these institutions, which typically have poorer healthcare outcomes than their nonprofit and public equivalents. We also recognize at the national view, 66% of Canadians support national standards and more federal control over long-term care. Nova Scotia and the provincial government are on board for national standard, as are most Canadians. When we ask for a national standard, there's a few things that we would like to see standardized, such as eligibility criteria and cost, minimum hours of care, compensation, restriction of harmful methods such as binding and drugging, which are still very common around the country, and standard indicators of care with the publication of that data. This helps by ensuring that existing resources are used more efficiently across the provinces, ensures a base quality of care across the nation, ensures consistency of measures so we can easily compare cross-province long-term care and determine gaps, and transparency of data help to create accountability in the system. We understand that this would be a negotiation involving all provinces and the federal government to determine where these standards will actually fall. We understand that each province has differing needs, and we don't want to set a standard that will limit others' ability to provide long-term care. To sell this national standard across Canada, we would use political pressure. Canadians want more standards and federal control over long-term care, with the lowest support being in Alberta at 54% and Saskatchewan at 49%, according to Angus Reid, and the highest support being in provinces like Ontario with 66% and Quebec with 77%. We also recognize that there's a window of opportunity. The public is on board to fix this issue, and we need to work within this policy window. We recognize that the federal government is unlikely to distribute more funds without standards, and therefore we need to all work together to get on board and make sure that this is ending well for us and our seniors. This probably is only going to get worse in Canada as our demographic shift. Our people have gotten older over the years, and our average age has shifted from 27 to 41. When provinces agreed to the Canada Health Act, we agreed that we would eventually address the issue of extended care services. These were purposely left undefined in the 1960s and 70s, and funding for these services gone without conditions. We need to change that and make sure that we're providing specific qualities of care and a baseline for everyone. We also recognize that standard care and standards does not restrict the ability for provinces to address their issue for customized care at the provincial level. With that, we have a few criteria that we would like to see in a national response. We would like to see funding that's in line with the OECD average, uniform standards that bring all provinces up to a baseline, feasibility, meaning it's compatible with existing systems, that it's actionable within the next 5 years, and that it's politically acceptable to governments and stakeholders.
Given these criteria, we have identified 3 options for a national response to the current crisis in long-term care. The first option would work within the current system, but push for an increase in Canada health transfers to bring funding in line with international norms. The second option would contemplate a new funding model based on a system of social insurance. And our third option would see long-term care established as a fully public service within the Canada Health Act. Option 1 seeks to work within existing systems of financing and care delivery, including our current mix of public and private providers. However, we would seek an increase in long-term care funding from the current level of $22 billion up to $29.5 billion. This increase, made incrementally over 5 years, would bring Canada's spending in line with the OECD average and provide the system with the funding it needs to meet new standards of care. We would propose that the costs be split 50-50 between federal and provincial governments. Such an arrangement would see the federal government take on a greater share of the fiscal burden compared to at present, where provinces pay fully 3/4 of long-term care costs. However, we argue that the federal government's commitments to national standards need to be backed up with a commitment for federal funding. In addition, while Canada health transfers are made on a per capita basis, we would argue that long-term care transfers should be proportionate to the population over the age of 75, as this is the demographic that primarily depends on long-term care. In order to implement national standards, the increases in transfers would be tied to and contingent upon provincial compliance with new national standards. In addition, greater transparency of health outcome data will create a mechanism for increased public accountability. Option 2 would create a new public insurance scheme to be funded through a 2% payroll tax or 2.5% for childless adults. All Canadians would be insured, and the scheme would pay out benefits directly to seniors in order that they could choose their own care agreements. Benefits would be needs-based and according to an independent at-home assessment. The insurance program would be complemented by standalone legislation to set benchmark standards. Enforcement would rely on data transparency for public accountability and on consumer choice to enforce discipline amongst care providers. Finally, option 3 would define long-term care as an insured health service under the Canada Health Act. This would mean that long-term care would be universal and publicly administered with no user charges at delivery. Essentially, long-term care would be administered and delivered the same way as hospital care or primary care. With no user fees, all funding would come from Canada health transfers and from provincial health budgets. As with option 1, federal transfers would be tied to minimum standards and transparency of data would establish public accountability. In addition, in a publicly administered model, care facilities would be subject to the internal accountability mechanisms of the Department of Health and Wellness. Comparing these three options, we recommend the first option to increase Canada health transfers within the existing system. While all three options provide for adequate funding and a uniform standard, option 1 is preferable in terms of timeliness and feasibility. We believe that the first option could deliver real results within the next 5 years. In contrast, options 2 and 3 would require major overhauls of how we approach long-term care. Whatever we propose needs to capitalize on the current political moment. The present public attention calls for an actionable response, not protracted rounds of systems-level negotiations. It is illustrative to consider the example of the United Kingdom, where an initiative to overhaul their funding model for long-term care was drawn out over 15 years of debate with multiple rounds of consultations, commissions, and reports, and still failed to achieve consensus for substantive change. With a crisis already on our hands and a demographic crisis looming on the horizon, we do not have the luxury of that timeline here in Canada. Our first option prevents the most realistic path forward for current reform and timely implementation.
Now I'm going to talk about the implementation of our option, which required both federal and provincial level. The key to federal implementation is to get all the provinces on board, which will be done by using the public support on this issue about federal standard and taking the advantage of the current policy window of the COVID-19. The main part of our implementation on the federal front will be increasing the Canada health transfer. We are proposing 9% increase over 5 years from current total CHT of 43.1 billion, which would be 750 million per year. And this increase in CHT will be allocated among provinces to reflect the demographics, not per capita. In case of the implementing the standard when it is developed, The provinces need to meet minimum standard and have to provide sufficient data to monitoring system so that the funding is disbursed to the provinces. And this implementation of standard will be reassessed in every 5 to 10 years through consultations. In case of the federal enforcement, it includes standardizations and reporting benchmark data and collaboration with the Canadian Institute of Health Information. We could use the lesson learned from the 2005 National Wait Time Initiative, which focuses on targeted funding, knowledge, and transparency in results. And the percent paid by federals towards LTC will be decreased if any province don't meet the standard. On the provincial front, we need to identify some department which need to be involved along with the Department of Health and Wellness, Department of Seniors, Department of Community Services, Department of Labor and Advanced Education. At the first stage, we'll have stakeholder engagement in consultation for 6 months. The identified stakeholders are elderly and representative groups, at-risk groups, families of LTC, private LTC providers, nurse and other representative groups, academics, and LTC policy experts. In the policy development phase for the first year, the priorities would be to ensure the provincial contribution of 21.7 million per year over 5 years. We have to keep an eye on the equity groups and their needs. The staffing is a key, especially their education, training, compensation, and ensuring labor standard. On the infrastructure development front, the strategy is to eliminate multi-client rooms and multi-client bathroom in the current facilities and building more bed. We'll focus on increasing more public options, and the enforcement strategy includes a reporting system for issues between inspections. For implementation, we need to focus on few issues like infrastructure development. The current investment need to be increased from 5 million to 10 million per year, and will prioritize public and non-profit private options over private facilities for new development, though we'll provide infrastructural support for existing private facilities to meet new standard. One of the key pieces of the execution is the care assignment. Comprehensive assessment is needed for every client effectively so that they could utilize the current space, especially the long-term care, community care, at-home care. This will reduce the number of those waiting in the long-term care for hospitals. Staffing is a key issue because we need to educate our skilled staff force and the labor pool so that they work in Nova Scotia. We need to increase staff wage and other benefits and improve labor standard to ensure fair treatment. On the provincial front, to enforce, we need to have a monitoring and review team, and this team require twice annual inspection per facility, and also there will be reporting process in between this inspection if there is any incident occurs. We'll ensure the transparency of health outcome measures too. There will be long-term evaluation. So the keys are monitoring the demand, especially the wait list. We assess how the wait list change with implementation of this option, and the staffing needs will also be reviewed. The outcomes will be reviewed by anonymous reports from facilities, clients, and their families, and standardized outcome measures. We'll ensure accountability, especially the inspection requirement from federal, provincial, territorial health ministry recommendations, and all the reports of this data will be for public review, and withhold of provincial fund will be done if any private institute are non-compliance. We identified some risk and have some mitigation measures for those. There could be political risks, especially interprovincial negotiation. We'll have a seniors first approach to mitigate any difference of opinion between the provinces. And from stakeholder consensus, we should use a public reporting, fines, and other systems so that all the stakeholders are on board. There could be financial risk because of the gray wave and the demographic shifts, because we are not getting younger as a nation. So there will be continuous evaluation to adjust the priority, and we'll work accordingly. Accessibility measures need to be taken, especially with the equity groups. We'll review the equity data and make sure those needs are met. There is a rural-urban divide, so more investment in rural options need to be ensured, especially for new facilities. There could be potential risk on human resources, so brain drain can happen. So we need to make sure use of grant and loan forgiveness to make sure our workers stay in the province. And the improvement of labor pool would increase that the working condition is there so that they don't leave the labor pool. The communication need to be done for all the groups. For example, the federal government, we need to tell them that they need to invest because to implement standard investment is a must. Other provincial government will tell them that the provinces will have more control and flexibility over the fund if they agree to a standard. Private sector LTC, they need to comply to the standard to get funding. Nurses staff, they'll be happy because we're including their benefits. Elderly and family will have better care for them. Healthcare sector will ensure them that more money is available within their budget. Taxpayers will, the key message for them is the healthcare will be free to meet their other needs, and also will ensure a better care for everyone, because most of us will need this service in future. So let's invest on this. So as COVID-19 has shed the light on this long-term care long-standing problem, I think together we can build our existing strength to deliver care, dignity, and quality of life to our seniors and others in need. Thank you.
Okay, thank you very much, colleagues. Thank you for this briefing. I'm the chair of our panel. My name is Jim Mitchell, and I'm the Deputy Minister here in Nova Scotia. I'm going to turn to my colleagues for their comments or questions. We've got 10 minutes to review your deck with you. I'll start with Steve Orsini. Steve, you could unmute yourself in your own way.
I really appreciate the presentation, very professional, thoughtful. One of the areas I'd like to explore a bit more as we participate in a national dialogue, and maybe this is captured in slide 18, where you kind of show the options and the different risks, or the evaluation of the options. I want to explore the political. Can you elaborate a bit more how each province or group of provinces will be supportive to these options or could be opposed? So I want to get a better sense from you where you think the other provinces will be on this particular issue.
Yeah, I don't mind taking that question. There are some concerns with provinces such as Ontario, Quebec, Alberta, who have been resistant to this situation of potentially introducing a national standard, mainly because they're concerned about level of control, as we addressed, as well as, especially in Alberta, federal transfers have been an issue historically. We would ask them to reflect on their public opinion within their provinces, even Alberta. The percentage of support for this concept is at 54%. The majority of Albertans want this. And I bet because that is a little bit of a dated, that's 2019 or 2020 report, that support has gone up since COVID-19 has taken bigger effects within our provinces. Provinces like Ontario and Quebec actually have the greatest level of support of this. And I don't think it's politically viable for them to stand against it when the majority of their citizens want this, as well as recognizing the catastrophe that's taken place with the current funding and standards level in those two provinces. We believe that there will be less pushback when we reflect on the fact that we are asking for more equitable cost sharing between the provinces and the federal government. So instead of, while we're implementing these standards, instead of having the 3/4 supported by the provinces in long-term care, it would be moving to a system where it's a 50-50 split, which we think is fair, considering that this would be a national standard enforced by the federal government. They need to give provinces a little more money if they're going to enforce the standard. So it's easier to reach and it's more palatable to all provinces to accept it.
Okay, thank you, Riley. Susie McDonald, comment or question, and then Janine Richaud.
Maybe and thank you for that, and thank you for the excellent presentation. And just following up a little bit on Steve's question and your response, I do wonder, we've often had a lot more success in negotiating with the federal government when we come together as provinces and territories with a single view. I'm wondering your view on this idea of having an age demographic. I mean, certainly that supports the Atlantic provinces and BC, but it doesn't support the provinces that we're trying to get on side, including Alberta, Ontario, and Quebec. Have you given that any thought?
I'll take it.
Robert Kitz, go ahead.
We are aware of that, and it is potentially a source of contention. At the same time, it is strongly reflective of where the actual demand for long-term care is. So putting aside for a moment the political, which is perhaps rash, but certainly it makes good sense that funding for long-term care should be reflective of the people who actually use long-term care. While it may require some negotiation with the provinces, at the end of the day, as the province of Nova Scotia, we also have to be cognizant of our own needs and stand up for a principle that would support our particular demographics.
Okay, thank you, Robert. Janine, over to you. You're muted still, Janine.
Yeah, thank you. I was just losing track of the button. Thank you, everyone, for your presentation. I really appreciate the thought that you've put into this. I do wonder, though, the Prime Minister and the Minister of Health have been clear federally that their preference is indeed a national standard. And we're arriving at the table. Your recommendation to us is to go to the table to help them push that message. But my question for you is, are we giving them too much of what they want? And what do we do if the direction of the discussions goes farther away from our interest? And what would you recommend to those of us who are going to be in Ottawa on this working group in order to really represent Nova Scotia's interest in this regard? My concern is that we're giving them what they want, but what is our bottom line in this discussion?
Team, who's going to speak to that?
To that,
Okay, Riley?
The concern, I think, is overblown to a certain degree. Again, we reflect back on what all provinces want. The citizens want this. So it's less about giving the feds what they want. It's about giving the citizens what they want and what are needed for elder care. That also goes back to the cost splitting structure, basically. The idea that the federal government wants to implement these standards and have a little more say and control. One, these standards would be negotiated at both with the federal government and the provinces. It would not be a federal government, steamroll of the situation, as well as the cost sharing methods. While they will be implementing these standards, they will be paying us more for them. And it will be reflective of need. So it's not that necessarily that they would be getting what they want. Our citizens and our provinces, especially here in the Atlantic provinces, we would be getting what we wanted. And we will be getting a bigger share of the pie from the federal government to fund our long-term care. So at the end of the day, whatever sacrifices that could be viewed that we're making, we disagree that these would be sacrifices and issuing more control to the federal government without any favors, because we want these standards and we want them to be enforceable and equal. We're also getting more money out of it, which we feel that balances out any concerns.
Okay, Riley, thank you. Go to Andre Fortier for maybe a penultimate question. Andre.
Yes, thank you. Thanks for the presentation. Just have a quick question. You raised the issue about giving the people what they want. But are we certain that people really do want to be in long-term care facility? Don't they want to stay home any longer and have home care more appropriately? And at the end of the day, the proposal is to put more money and more resources into long-term care facilities, which is not necessarily what the people are asking for.
Yeah, actually, oh, sorry.
Riley,
no, it's okay. Maybe yeah. Could it be a counterpart of the proposal?
Yeah, absolutely. It's absolutely part of our standards. And we had lots of discussions about this. The biggest issue here in Nova Scotia is that we do have options for aging at home. And because of that, the people who are entering our facilities are older and have more complex needs. Our approach, as we discussed with needs assessment, would be to make sure that the people who are going into these facilities are people who need intense levels of care, to make sure that we're using our resources more effectively, meaning that people who do not have intense levels of care and want to remain in their homes can as long as possible. That is definitely a priority of our system.
But don't you
so
think
colleagues, I'm going to ask one. Oh, sorry, yeah. Andre, go ahead, Andre.
No, I just wanted to make sure if you, given the way the standards could be designed, would not be an adverse effect that provinces as well as federal would put anyway more money into long-term care facility and we don't have enough money for other possibilities.
It's
you
when
look-
we talk about funding for long-term care in our model, it refers to long-term funding as a concept, not specifically long-term care facilities, though it does have an emphasis on that. Our model definitely is inclusive of the fact that the national sector standard is to keep people in their homes as long as possible, to improve their quality of life. While it refers to long-term care as a concept, we are reflective of the fact that it is long-term care is inclusive of at-home care.